Greetings, everyone. Welcome into the webinar. We're just going to give a couple more minutes for people to come in and we will get started uh, very soon. Okay, well, let's get started. Um, good morning, good evening, good afternoon, everyone. Welcome to today's webinar. We're thrilled you're able to join us. And my name is Sean Lassiter. I am the Assistant Director of Learning and Development. Um, I'm helping to facilitate this session along with my colleague Rob Aldridge. Before we dive into the lecture, just a few couple important points. Just letting everyone know that this webinar is being recorded, and then it will be made available to everyone after the session is over on our website, on the page where you registered for the event. Um, you can use the you can use the Q&A feature on Zoom to submit questions at any time throughout the webinar. We'll have a dedicated time at the end of the lecture to address all questions. So feel free to engage in the chat throughout the session. Um, just so everyone knows also that everyone is muted and cameras are off by default. Um, and with that, we'll get started. Rob, I'll turn it over to you to introduce yourself and jump in. Thanks, everyone.
Great. Thanks very much, Sean. Good afternoon, morning, evening to everyone, depending on where you are around the globe. It's my pleasure to take this session today on interpreting GBD measures. Here is a brief agenda of what we're going to cover today. We're going to talk about the challenges of using GBD measures and what this training has been developed for to address those. And to do that, we're going to talk about a range of different GBD measures: life expectancy, HALE, YLLs, so years of life lost, YLDs, years lived with disability, and DALYs, disability adjusted life years. We're then going to talk about how we use a various range of metrics, numbers, rates, and percents with these measures. And then we're going to finish at the end of the session around age standardization and the importance of that. So by the end of this session, we hope that you'll be able to compare these different measures and metrics and be able to use age standardize and all age rates appropriately and know when to do that. The reason for doing this is that we are based at the Institute for Health Metrics and Evaluation, where we run the Global Burden of Disease study. We are an independent population health research organization based within the School of Medicine. And we're aiming to, with this training, tell you more and be able to help you use the results of our fantastic Global Burden of Disease study. For those of you that are relatively new to the GBD, the Global Burden of Disease Study, it is a systematic scientific effort to quantify the magnitude of all major diseases and risk factors around the globe from 1990 through to whatever the latest year is. There is a really nice study that our director and founder, Chris Murray, published in Nature Medicine that's linked to on the right here. And if you want to read more about the GBD study and find out about some of the more details, points of it, some of our strengths, some of our weaknesses, it's a really fantastic paper for you to read. And it goes over why the GBD is a rules-based evidence synthesis for global health and what we mean by that. The important part and underlying rationale of what we do within the GBD is the fact that we believe that everyone deserves to live a long life in full health. And as we go through the session today, you'll see that the measures and the metrics that we use enable us to look at that. And using these measures and metrics, we aim to provide a comprehensive picture of what disables and kills people across countries, times, ages, and sex. In the very recent publication of GBD 2023 that came out just a couple of weeks ago, the GBD is ever expanding. And so each iteration of the GBD gets bigger and gets more complicated and gets more detailed. And so this is the latest scope for the GBD that we just published, where we had 375 diseases, over 3,000, just under 4,000 sequela, 9 impairments, 88 risk factors, and 46 etiologies or pathogens that we break different infectious diseases down by. We produce all of these entities for 925 locations. So whilst we have many national locations where we do it for the country, we also have 20 countries where we produce subnational estimations listed down here on the bottom right-hand corner. And all of these estimates are produced for all ages, 25 age groups. As I mentioned before, we do it from 1990 through to 2023, and we produce all of our estimates for both males and females. Now, today we're going to focus on the summary measures, which are on the right-hand side of this plot. But we also produce a number of demographic, a number of mortality, morbidity, and covariate and risk factor estimates that are listed on this page here. So the GBD is a really comprehensive study that has a number of indicators and measures and metrics that we use throughout the study. And the study is only possible with the collaboration of our fantastic collaborator network. I'm sure several people on the call here are part of that collaboration network. There are over 17,000 collaborators now, and we really rely on you and these collaborators to help us perform the study and check the study and supply data and work with us to produce what is a really comprehensive disease study of global burden of disease. And this is the latest capstone, which came out on October 18th, and it was published in The Lancet. So hopefully at the end of this session, you'll be able to understand and interpret a bit more around the measures and metrics used within that study. Okay, so that's a little bit of a background around the Global Burden of Disease study. And what I'm going to do now is jump in and start to tell about how we interpret and use the different GBD measures. So when we're thinking about GBD measures, we need to think of deciding what to use and how to use them. We need to understand a few different things. So we need to understand what each value means. We want to also understand and determine what question it is that you're trying to answer. So whether you're a researcher, a policymaker, a student, you're going to need to know what is it, the question that you're trying to answer to be able to work out which is the best measure and metric for you to be able to use. And then that will enable you to decide what value best answers that question. So let's take a thought exercise here. On this plot, we have malaria, we have YLDs, years lived with disability in Mozambique, for both sexes, all ages from 1990 to 2023. And you'll see that we have YLDs expressed as a number on the very left-hand plot, which is going up. We have a rate on the middle plot, which is the rate per 100,000 population, which is going down. And we have percent on the very final plot on the right-hand side, which is always going down. Sorry, not always, it is also going down. So what does all this mean? They're all presenting data for YLDs, but which of these different measures and which of these different metrics do you want to use? And we hope by the end of this training, you would be able to understand and use that. And whether you would want to even use YLDs or whether you should actually be thinking about YLLs or DALYs as your best measure. So there are a selection of different measures that we produce within the GBD, as I started to allude to earlier. We have disease frequency measures such as deaths, prevalence, and incidence. We have life expectancy measures, including HALE, healthy life expectancy. And then we have health burden measures such as YLDs, YLLs, and DALYs. And we apply to these measures a number of different metrics, including numbers, rates, and percents. And percents are a little bit different in the GBD context, and we'll go into that later. So let's start off and dive straight into some of our GBD summary measures. And the first two we're going to address are life expectancy and HALE. So when we think about health, we typically think about our own personal experiences as individuals. We all experience health challenges in our lifetime. We get sick, we get injured, we get a disease, and some of us will live a long life, and others, unfortunately, have shorter lives. But to help us all live long lives in full health, we need to understand what is affecting our health. Why we are sick, injured, and dying at a population level, and that's important, thinking about that at a population level. Summary measures of population health allow us to quantify the overall health status of a population across a variety of dimensions, including age, sex, and time and location. So for life expectancy, that first measure that we're going to talk about today, life expectancy is the number of years that a person is expected to live at a given age, assuming that they experience today's age-specific mortality rate. As you can see in the image, the older you get, the longer you are likely to live. So the estimated age at death, as people increase in age, is increasing over time. So starting here at 73, and as an individual ages, shown by that calendar in the middle to 30, it's already moved up to 80 at the age of 50, and it's increasing. So let's just look at this a bit more and think about it in a bit more. How do we calculate this? Well, the global average life expectancy at birth in 2023 was 74 years. A common misunderstanding of this number is that the average person alive today will live to be 74 years old. This is incorrect because life expectancy is age specific. Life expectancy is an average measure for a population. Many poor people will die before they reach their life expectancy, and many more will also live longer than their life expectancy. It's not a guarantee of how long any one person will live, but rather a useful tool for overall understanding the overall trends. So as we see on this table here, we have two individuals, one at age 0, and their life expectancy is 74, and their expected age at death is 74. As per that previous plot, the individual who's aged 50, their life expectancy is 30, and their expected age at death is 80, meaning they're expected to live another 30 years and die at the age of 80, assuming, importantly, that mortality rates do not change in the future. Now, since 1950, global mortality rates have on average dropped, resulting in really impressive life expectancy improvements, as you'll see on this plot. So this plot here shows that life expectancy in birth between 1950 and 2020 has improved massively, as you can see, as you go from the left-hand side, where the lowest life expectancy in 1950 was around 40, through to the right-hand side, where that had increased to 55 and up to over 70 in the high-income groups. This is a really impressive achievement that's occurred over this time period. So that's life expectancy, but what do we mean by healthy life expectancy? It's a slightly different measure, and it measures the number of years that a population at a given age can expect to live in good health if current rates of mortality and disability remain. So the illustration here shows the life expectancy on the bottom and in the blue, and you have an individual born and they're healthy. They experience a period of ill health, and then they're healthy again, and then they have ill health, and then they experience an early death. Healthy life expectancy is life expectancy minus these periods of ill health measured by years lived with disability. That is how we calculate HALE. So HALE emphasizes that there are two ways to think about improving population health. This is bringing it back to our vision of all people living long lives in full health. We can either improve health by extending the length of life, but also by improving health. So you can improve life expectancy or reduce the years lived with disability. Either of these two will improve a population's estimated HALE. So let's look at an illustration and a moving illustration of hail and how that compares to life expectancy. So on the previous example of this moving image, we had age going up and life expectancy going up and age at death going up. Here, instead of life expectancy, we have hail, but we have the YLDs, the years lived with disability component, removed from that life expectancy. And this just illustrates what we mean and how we calculate hail. Let's go through a worked example for Lao People's Democratic Republic. On the left-hand plot, we have life expectancy for both ages from 0 to 6 days, so at birth. This is the GBD terminology for at birth. And on the right-hand plot, we have both sexes, 0 to 6 days for hail, in both plots showing the same country, Laos. You'll see that life expectancy and hail both improved between 1990 and 2023. Here on this plot, we have hail, both sexes at birth on the left-hand plot, and the YLD rate for all causes. So the years lived with disability for all causes, both sexes and all ages. Hail, as per the previous plot, is going up, but the YLD rate is essentially stagnant. And then finally, we have a final set of plots where we have hail on the left-hand side and the death rate on the right-hand side. Death rate was going down substantially over the time period with hail going up. So what this means is we had stagnant YLDs, apologies, and death rates that are going down. So if we have death rates going down and stagnant YLDs, this means that most of the improvements in hail in the last 30 years are due to improvements in mortality and therefore life expectancy, and not improvements in YLDs. So that covers what we're going to talk about today on life expectancy and hail. And now let's move into the second set of measures that we're going to describe. So YLLs are years of life lost, and they measure the cumulative years of life lost due to premature death in a population. YLDs are years lived with disability. They measure the equivalent years of healthy life lost due to disability in a population. DALYs, or disability adjusted life years, measure the years of healthy life lost due to premature death and disability. These are the three measures that we're now going to go into. Let's first talk about YLLs. So on this same illustration here, YLLs go beyond counting just deaths, and they also consider the age at death. So let's talk about this individual who's born, then experience poor health, they're healthy again, and then they experience an early death. YLLs measure that gap between their early death and the expected number of life years that they were expected to live. So how do we interpret YLLs versus deaths? Here we have the YLL calculation. So YLL is a summary measure of health loss that quantifies the years of life lost due to premature mortality in a population. Premature mortality is assessed relative to benchmark life expectancy for each age group, and the benchmark is determined by taking, for each age group, the lowest observed mortality rates among countries with a population greater than 5 million. YLLs are calculated as the number of age-specific deaths multiplied by the remaining lifespan according to the benchmark life expectancy for that age group. The GBD assumes that the longest possible life is theoretically achievable regardless of what year you were born, what sex you are, or the location of your birth. And this is an important philosophical point within the GBD study. So let's just talk through a bit of an example here about what we mean by age-specific benchmark life expectancy that I just talked about. You can think about benchmark life expectancy as the best case observed life expectancy globally, and it is higher than your actual life expectancy. Take a look at the table. At age 0, the benchmark life expectancy is 90 years, but once you reach 90 years old, the benchmark life expectancy is another 9 years, aged 99. So for YLLs, this means that a death at age 0 counts for more YLLs than a death at age 90, regardless of the cause of death. 2 deaths at age 0 would be equal to 180 YLLs, while 2 deaths at 90 would be equal to 18 YLLs. Everyone deserves to live a long life in full health. Remember this as the vision for, and what we're aiming to achieve at IHME with the Global Burden of Disease study. The YLL measure quantifies that long life part of our statement as a mathematical definition. YLLs can provide insight into how mortality trends are changing since it captures both premature mortality and death. How old people are when they die can tell us a really important story about our country's health. Because someone, for example, who lives to the age of 90 has gone most of the way to achieving our vision of living a long life in full health. And they contribute many more YLLs to someone who, for example, a child at age 5 who dies, unfortunately. They miss out on much of this long life part of the definition. You can improve YLLs or reduce them by increasing the age at death, reducing premature mortality, and by reducing the frequency of deaths. So let's dive into another worked example. Let's look at this example from Korea, where on the left-hand side, we have the YLL rate, all causes, both sexes and all ages. This is the rate, so it's per 100,000. And then on the right-hand plot, we have for Republic of Korea again, the death rate, all causes, both sexes and all ages. On the left-hand side, we see that the YLL rate is going down over time. And on the right-hand side, we see that the death rate is relatively stable. So what's going on? As we said, that YLLs capture both the frequency of death and the age at which people are dying. Stagnant all-age death rates and decreasing all-age YLL rates are evidence that people are now dying at later ages. So there's been some kind of health improvement related to premature mortality. What is that? Well, YLLs equal the number of deaths multiplied by the benchmark life expectancy. So if deaths haven't changed, then the remaining by benchmark life expectancy must decrease in order for YLLs to decrease. This in turn suggests that people are living longer before they die. Let's just take a knowledge check for 1 second. If all age death rates remain relatively stable between 2000 and 2010, but we observe an increase in YLLs, what might this tell us? Does it tell us that more older people are dying or that more younger people are dying? YLDs, or years lived with disability, measure the equivalent years of life of healthy life lost due to disability in a population. They're conceptually similar to YLLs. With YLLs, younger deaths cause more life lost than older deaths. With YLDs, some diseases can cause more non-fatal, non-death health loss than others. We just can't look at prevalence in order to understand the impact of the disease has on a population. You also have to consider the disability associated with the prevalence of a condition. So YLDs are based on the years spent in ill health. They measure on this illustration here, these periods of ill health in orange in an individual's life. So how do we calculate YLDs? We calculate YLDs by multiplying the prevalence cases by the disability weight associated for a particular condition. Prevalence is the proportion of a population with a health condition at a specified point in time, the point prevalence. Disability weights are a measure of severity of disability for different health states. So here, you can reduce YLDs by either reducing prevalence of a condition or by reducing the disability weight experienced by that condition. Here we have two ranks that show on the left-hand two columns between 1990 and 2023 global prevalent cases for all ages, both sexes per 100,000. So on the left two plots, we have two ranks for prevalence. And on the right-hand side, we have ranks for 1990 and 2023, the rankings for years lived with disability, YLDs. You'll see that in 2023, the most prevalent case it was that we measured, the highest prevalence of a condition was permanent caries or tooth decay. But on the right-hand side, the highest ranking YLD cause was lower back pain. So permanent caries or tooth decay are not on this YLD ranking at all. Why is that? Why do we not see it? And why do we all of a sudden see lower back pain? Well, this is due to the disability awaits of both low back pain and tooth decay. Tooth decay having a very low disability weight, meaning that although it's very prevalent, it contributes a very small amount to YLDs. So here we illustrate that each cause is associated with a series of health states. So you'll see that we have mild distance impairment with a very nearly zero disability weight, severe and acute infectious disease episode of just over 1, severe back pain, the highest cause of YLDs was 1 over just over 0.3, bipolar disease just under 0.5, and spinal cord lesions are just over 0.7. So each of the causes is associated with a series of health states. These are asymptomatic or symptomatic, and the disability weights are assigned from a 0 to 1. It's important that no health state can have a disability weight of 1. Again, this is a philosophical approach for the GBD that says that no disability a person can experience is equivalent to that of death. So none of our causes have a disability weight of 1. A person who experiences, as illustrated by this example here, severe back pain for a full year would experience about 0.3 YLDs. They would need to experience constant severe back pain for 3 years to equal 1 YLL, equivalent from dying prematurely for 1 year. YLDs allow us to capture the health loss from different disabilities, and they also allow us to better compare health loss from mild distance vision impairment through to really severe disability conditions to spinal cord lesions at the neck. The unique contribution they make is being able to make that comparison across these very two different causes of ill health and disability. Diseases with higher disability weights make up a larger share of YLDs than they do for prevalence. So we can see that back pain increases significantly, while oral cavities have much lower impact, as we saw in that previous plot. This is the result of those different disability weights. Here we have a tree map which shows the total burden of disease, and then we have it showing prevalent cases as on the screen now, and then YLDs as on the screen now. So it's showing how different causes move as they go from prevalent measures of prevalence and YLDs, essentially illustrating the impact of the disability weights on those different causes and how they are measured in YLDs. Well, let's go through another example to illustrate this more. Let's take a look at HIV/AIDS between 1990 and 2023. So on the left-hand side, we have prevalence of HIV/AIDS per 100,000 people globally for both sexes and all ages. We see that it's going up in 1990. It plateaus a bit in 2000s and it continues to increase up to 2023. So prevalence of HIV is increasing over this time period, doesn't decline. Unlike the YLDs rate, which again, YLDs per 100,000 for HIV/AIDS between 1990 and 2023. Here, when we're measuring YLDs, we see that it increases until the early 2000s when it starts to plateau. And then from the 2010s, it then starts to decline. So why are we seeing that YLDs are dropping whilst prevalence is increasing? Remember, prevalence can increase. If prevalence is increasing, disability weights must be decreasing for that to equal a decreasing YLDs, since YLDs are prevalent cases multiplied by the disability weight. What this is actually illustrating is the massive improvement in treatment that was available for HIV/AIDS since 1990s. That improvement in treatment has meant that there's been an overall decrease in the disability weights associated with HIV as people end up on treatment and their disability experience is reduced. By accounting for these improvements in treatment and the disability weight experienced by individuals on treatment for HIV/AIDS, we're able to measure health loss and make comparisons across health outcomes, locations, and causes as treatment changes. This is a really key aspect of the global burden of disease study that we think is a particularly innovative and useful way to make comparisons across countries and time. Finally, we're going to talk about disability adjusted life years within this section of the talk. Disability-adjusted life years measure the healthy life lost due to premature death and disability. Essentially, DALYs are measuring the sum of both the YLL component and the YLDs. They're the sum of these two components. So they measure the ill health parts in orange, and they measure the early death part in the red here. They're the foundational metric within the GBD study, as they capture both fatal and non-fatal health burden and allow us to compare the total disease burden, fatal and non-fatal, across time, location, and locations. Here we have a graph of the DALY rates globally from 1990 to 2023. DALYs allow us to measure all health loss across these locations on the same scale. Within the DALYs, we've highlighted YLLs in the slightly higher red, the shade of red, than the YLDs in the kind of more pinky orangey color at the top of the plot. So YLLs are at the bottom of this plot and the YLDs are at the top. YLLs shed light on the impact of premature mortality, whereas YLDs highlight the burden of disability. And together they capture the importance of both extending life and of improving its quality. Fewer DALYs are better than more DALYs. It indicates that there are fewer years of life lost or fewer years of disability in a population. Over the last 33 years, YLL rates have decreased dramatically, decreasing the DALY rates. YLD rates have actually increased slightly and now make about 1/3 of the total DALYs. So 21% of DALYs were due to YLDs in 1990, whereas 35% of DALYs were due to YLDs in 2023, as illustrated here. Here on this plot, we've got 4 tree maps that capture what proportion of health loss is attributable to each cause within the GBD cause hierarchy, with deaths on the top left, YLLs on the bottom left, YLDs on the top right, and DALYs on the bottom right. Deaths tell one story about life. There's lots of blue, blue being in the GBD color scheme, non-communicable diseases. YLLs tell a slightly different story about life lost. There's more red. This is our measure of communicable maternal and neonatal diseases. YLDs tell a different story too, much more blue due to non-communicable disease. And when we put everything together as a summary measure with DALYs, we can capture everything we know about death, age at death, prevalence, and disability in that single measure, giving us an extremely comprehensive picture across all causes. So when we're thinking about these different GBD measures, we need to think about the metric that we're presenting them with. And as I alluded to earlier, we have 3 different main metrics that we use within the study. We have rates, numbers, and percents. Rates are the number divided by the mid-year population, and they're often reported per 100,000 individuals. We calculate rates by dividing population. Rates make it easier to compare health burden across geographies and across time. So let's look at a worked example here. We have here on this plot, we have numbers of deaths in Nigeria on the left-hand side for all causes, both sexes and all ages. Deaths counted on the y-axis, going from 0 up to 1.5 million, or actually higher than that, about 2 million. On the right-hand side, we have rates, all causes, both sexes and all ages, again for Nigeria. And starting in 1990, it was just over 1,500 per 100,000 death rate, going down into 2022 to around about 600 or 700 per 100,000. Remember, death rate is the deaths divided by the population. So if the number of deaths is going up, as it's shown on the left-hand side, and then stagnant, but the total death rate is going down, what does this mean? How can we have a death rate going down when the number of total deaths is remaining stagnant? The explanation for this is that the death rate is the deaths divided by the population. And as we'll see here, this is the population of Nigeria, which increased substantially over the same time period, going from 90 million in 1990 to 231 million in 2022. By including and dividing the number of deaths by the population that was increasing over time, with a much more comprehensive picture of Nigeria's health over that time period, making it comparable more than we can just by looking at the total count of deaths. We can also use rates to compare changes over locations. So rates allow us to compare health outcomes across countries with vastly different population sizes, from China, the largest country in the world, to small island countries that have a very small population. This enables us to inform evaluations of health across these two very different settings. If we used numbers alone, we wouldn't be able to do this because the largest countries in the world would dominate the narrative about deaths. But once we correct for the population size by using rates, we see a really different story about the burden of deaths around the world. Rates allow us to assess health even as underlying populations change over time. So the maps that we have on this slide here show the death numbers in 2023 on the left-hand side and the death rates on the right-hand side per 100,000. If we're just looking at the total numbers of deaths, you'll see that India and China stand out. Just due to their sheer population size, they're going to have more deaths than any other country. Whereas when we adjust and account for the size of the population on the right-hand side by dividing the number of deaths by the total population, we get a much better and more accurate picture that compares health across countries by accounting for the different sizes in the population. This shows the importance of using rates when we're considering GBD measures. But while rates are useful, they do adjust for population. Numbers can still be valuable, especially in certain contexts. For example, numbers can clearly illustrate the impact of acute events like we saw in the COVID pandemic, where often we were reporting just the number of cases over time. Numbers represent the count for any measure, the number of deaths, the number of DALYs, or the number of prevalent cases. So let's just take a knowledge check here. Which of these two values do you think better conveys the scale of COVID-19? Do you think it's 7.9 million global deaths in 2021? Or do you think it's 99.95 deaths per 100,000 in 2021? Which of these two numbers do you think is more understandable to most people? Let's take another illustrative example and consider the opioid epidemic in the United States. Here on the left-hand side, we have the number of opioid use disorders in the United States of America for both sexes and all ages. And on the right, and the number of deaths due to that, should say, which go up dramatically between 1990 and 2023. On the right-hand side, we have the rates of opioid disorder deaths in the USA by both sexes and all ages. Again, the death rate goes up quite substantially, but they tell quite a different picture, one of which I think is much easier to understand if we talk about the number of deaths rather than the rate of deaths. So if we talk about the number of deaths and the fact that there were almost 70,000 more people dying in 2023 from opioid use disorders compared to 1990, this is a very easy and quite substantial number for people to talk about, to understand. Versus there are 20 more deaths per 100,000 people in 2020 rather than 1990. I think that hopefully you'll understand and see that the just reporting on the number of deaths is much more interpretable and easy for most people to understand. Okay, the final metric that we're going to talk about is percent. The percent within the GBD context is the number divided by total health burden multiplied by 100. And percent in a GBD context capture the relative importance of causes in comparison to total health burden. Here we have the illustration of how percent is calculated. Percent is the cause-specific count of whatever measure you're thinking about, divided by the sum of that same count from all causes, rather than the cause-specific, multiplied by 100. So by percent, we mean the percentage of total health loss in a population attributable to a particular cause. Every cause makes up a percentage of total health loss. And if you add up the percents from all the causes, that's where you get to 100. So, for example, taking a look at the percent of DALYs from HIV/AIDS, we see significant variations in health loss across countries. In this map, each percent represents the percentage of all health loss attributable to HIV/AIDS in a specific country. In Slovenia, it's only 0.016 of all DALYs due to HIV/AIDS, while in Lesotho, is 27.51 of all deaths due to DALYs are from HIV/AIDS. This does not mean that 27.5% of global HIV/AIDS DALYs are in Lesotho. What it means is that 27.5% of the DALYs in Lesotho are due to HIV/AIDS. You can see this by looking at this Lesotho tree map, where HIV/AIDS makes up 27.5% of all the boxes on here. Tree maps capture how all different causes contribute to the total health lost. You can look at GBD compare training if you want to understand more about tree maps and how to use these within your presentations and within your work. We can also examine changes over time using percents. They're a really useful way of considering changes over time. So globally, 47% of DALYs were due to communicable, maternal, neonatal, and nutritional diseases in 1990, dropping to 24% in 2023. This shift away from communicable maternal and neonatal diseases is called the epidemiological transition. And as countries go through this transition, their health burden shifts from experiencing primarily non-communicable diseases to experiencing primarily non-communicable diseases, requiring them to adapt their health policies and resource distribution. Understanding this transition and where a country is within the transition is really useful information that country decision makers, researchers, and the public can have at their fingertips using this sort of measure and metric. Percent should be looked at, however, alongside number and rates in order to understand the full picture of health. So whilst percents provide valuable insights into the distribution of health loss across different causes, they can also mask the impact of significant events such as COVID-19 on the overall health burden. They also hide changes in rates and numbers over time. So looking at the same data here on the rate space, you can see that rates have been declining with an increase due to the COVID-19 pandemic. Looking at the same data in the number space on the far right-hand side plot, you can see that the numbers stayed relatively constant over the last 30 years, but there's still an increase from the pandemic. Percents, the plot on the very left-hand side, should be interpreted alongside numbers and rates. And to get a full understanding and picture of health, sometimes it's necessary to consider all of these metrics when applying them to GBD measures to get a full understanding of what is going on and to be able to describe that picture and tell that story of population health burden. Finally, I just want to make this final point that because percents can sometimes be confused with rates. So rates at the top are the core specific count divided by the population, whereas percents on the bottom is the core specific count divided by the total health burden. In both of these metrics, the numerator, the top part of the equation, is the same core specific count. It's the denominator which varies. For rates, it's the population, and for percents in the GBD context, it's the total health burden. So that is our summary of metrics that we apply within the GBD, the rates, numbers, and percents that we very commonly use. And which one you choose depends on the question that you're trying to answer. As I've been talking about, effective storytelling in health relies on selecting the most appropriate metric for the situation that you're trying to convey and the story you're trying to tell. We've been examining how rates, numbers, and percents can help us interpret GBD results in different ways. Let's now finally turn to age standardization that can help us to explore the effect of age on these different rates, numbers, and percents. As a reminder, all age estimates capture the health of everyone in the population at all ages. Within the GBD study, we also make estimates for 5-year age groups, and under the age of 5, we do them for smaller age groups, including 0 to 6 days and 7 to 27 days, early and late neonatal groups. As you can see on this plot, which shows each age group and then the percentage of total DALYs, you can see that we see very different causes of disability measured by DALYs by different ages. So the under 5 age group experienced the most burden in red from our group 1 communicable and maternal diseases. The young to middle age group see the most green from injuries, And the older age group see far more blue and purple from non-communicable disease, particularly chronic respiratory diseases. So we see a very different pattern of causes of disease across different age groups, which makes comparisons more complicated. How do we address this? Estimates for age-specific groups can be more useful than looking at all age estimates as we were considering earlier. And understanding the ages of people in different locations is essential to understand health patterns. So to be able to understand these health patterns, we need to understand the different age patterns within a location, because depending on what you're interested in, looking at estimates for that age-specific group could be much more useful than the all age estimates, which can hide substantial differences in health burden. Different locations have very differently aged populations. So, on the global scale, it's really important to understand this because some countries may have more children than old people, while others may have larger older population. And age structures, as we illustrated on that plot earlier, have dramatically different effects on the population health burden experience. In particular, also, we can see and we know that age structures can change dramatically across countries. And so, taking account of this, taking account of baby booms, large migrations, and disasters and wars that can have substantial impacts on population structures, age structures in particular, to do this, we need to be able to we need to be able to do this to understand the health burden within a population. Now, when we're wanting to compare across populations and countries, one way to account for these very different age structures is age standardization, which is a method for comparing rates across populations that removes that difference of having different age distribution and age structures. What do we mean by all age versus age standardized? All ages reports, when we're reporting in all ages, we're talking about all cases across all age groups from 0 to 95 plus, reporting rates, numbers, and percents. Age standardization is a method for comparing rates across population that removes the influence of those ages and generally we do age standardization when we're reporting rates, and occasionally we do this for when we're reporting percents. Let's take a worked example to illustrate this further. So here we have a map of neoplasms or cancer for all ages. And the GBD measure that we're looking at here are DALYs per 100,000 for both sexes, all ages in 2023. We can see a higher rate of cancer DALYs in countries throughout Europe on this map, and lower rates in other parts of the world, including parts of Africa and the Middle East. For example, Hungary, illustrated in red in Europe, has very high rates, whereas Ethiopia has much lower rates in blue, also highlighted with the red circle. But we know that cancers are much more likely to occur in older populations. So what does this mean? Some cancers can occur in young people, but the very different age structures that we might expect in these two countries could be having an underlying important impact if there is a difference in the number of people in the older age group across these two countries. Here we have a population pyramid for Ethiopia in 2017. A population pyramid is a graph showing the total number of people in each age group. In the case, in this case, we have males on the left-hand side and females on the right-hand side, and age on the y-axis with the youngest at the bottom and the oldest 95 plus group at the top. This population pyramid is for Ethiopia, and you can see that it is pyramid shaped with many more children at the bottom and far fewer people in older age groups. Let's now look at Hungary for 2017. Here we see a very different picture. We see very large populations in the middle groups between about 40 and 70, and much smaller populations under the age of 25. This structure is going to affect on cancer rates and our ability to compare cancer rates across Hungary and Ethiopia, as we saw on that first map, given the very different age structures and the fact that we know that cancers have much higher rates in older populations, which are going to be much more common in Hungary than they are in Ethiopia. It's therefore not surprising when we look at all age rates that Hungary is higher. Here we have the global age pattern for 2017. And as you can see, pattern is somewhere between Ethiopia and Hungary. This is where age standardization comes in. Age standardization works by scaling the populations of each group either up or down, to match that standard global population distribution. This method allows us to compare rates across population and removes the influence of having different age structures across that population. So what this means is that in Ethiopia, we increase those in the middle years, and in Hungary, we increase those people in the younger years. So let's look at the all-age map again for cancers, 2023 DALYs, the rate per 100,000, with Hungary and Europe in the higher having the higher rates and Ethiopia having lower rates in blue. And here and now we have the age standardized map of cancers, DALYs per 100,000. What we've done here is adjust every population to look like the standard global population. This now allows us to make comparisons of countries despite their very different age structures. Suddenly, the map looks really different. Hungary and Europe have medium rates of neoplasms or cancers, and we see that new countries emerge, including Ethiopia now, which is suddenly orange, Madagascar and Mongolia too. Both of the maps that I've shown you are correct. It is true that the highest all-age rates of neoplasms and cancers are in Europe, but there are still high rates from cancers in specific age groups in other countries. High rates that are obscured when we're just looking at the all-age rate and only become obvious when we do this age standardization here. Can you think about another cause with a strong age pattern, perhaps one that has a younger age group? Such as an infectious disease potentially. How might age standardization change that global map for all ages in that context? Okay, we're coming to the end of the session now, and we're going to go on to conclusions and next steps. So hopefully I've given you an introduction into a range of different summary GBD measures: life expectancy, HALE, YLLs, YLDs, and DALYs. We also talked about a range of different GBD metrics that are very commonly used: rates, numbers, and percents. And then finally, we've looked at trends across time using all age, age specific, and age standardization. In future lessons, we can come back and look at percent change, annualized rates of change, and uncertainty levels, which are really important within the GBD study. Please come back to our trainings, and we can delve into these issues more into the future. I am going to stop here and take any questions at this point.
Thank you, Rob. A few questions have come in. One question is, do you have any advice for UW grad students interested in getting involved in research with the GBD study?
Yes, email me. Well, Sean, I don't know if you were going to say something different, but I can put you
Oh,
in
well, I was
contact
just
with.
going to say,
Yeah.
yeah, there are some, at the University of Washington, there is a um, Department of Health Metric Sciences, which offers graduate study in on GBD and other methodological approaches to health metrics, and so that's
Mm,
probably a first step at the university. Um, uh, so that's the I think the best recommendation.
yeah.
There's another question: Is the GBD 2023 public? Is it GBD 2023 data public access, or do you have to be a collaborator to use the data?
And no, it's public access. You do have to do now, I believe, correct me if I'm wrong, Sean, provide an email and create a password to download the data. And if you download a lot of data, there is now a kind of request where we review the very substantial downloads. But otherwise, yes, we consider the GBD study to be a global public good, so it is publicly available with registration.
Yeah. What statistical analysis skills are needed to analyze GBD data? Is the analysis done in R or in Stata?
The analysis that we present is done in a range of different packages by different teams, but in general, it's R and Python. But then I would say, as an external user of the GBD study, when you're download the data. It would be up to you really to use the whatever statistical package that you wanted to use. But within internally, we use a very wide range of packages, including R and Python.
Um, are deaths resulting from wars and insurgencies included in the GBD death data for countries?
Yes, they are. I do not work on that. The Global Burden of Disease study has just under 500 people working on it. And I work on the non-fatal side and particularly using healthcare record data. That's kind of my expertise within the study. Um, I know that we do use we do count deaths from wars and insurgencies, and we use a particular um, set of data, which I forget the name of right now, but you will find that if you look at the paper by Mohsen Nagavi that was published in the Lancet a couple of weeks ago, GBD 2023, I'm fairly certain that they will reference the source of those deaths, war for war and insurgencies within the paper.
How is disability weight estimated? Can you say more about that?
Yes, this is a common question, and it's also a really complicated aspect that it would be a whole kind of 1 hour seminar just on its own. And in general, I can kind of give some very high level principles just to kind of illustrate the point. Essentially, there were a series of surveys where individuals were asked to compare and rank not rank, compare different health states. So, for example, they were asked to say, which would your personal preference, which would your personal, in your opinion, be more substantial health burden? Would it be living with 1 year of back pain or 1 year with visual impairment? And that was the survey that was conducted was done on tens of thousands of people, and then the results of that were synthesized. I think the surveys were conducted from around about 2010 to 2017, and then synthesized and been used then. There's a paper by Joshua Solomon that goes into a lot more detail if you want to find out more on that.
So, um, another question coming in is, what are some of your current research projects focused on the GBD?
I presume that that question is literally meaning me. So if I talk about my research, I'm focusing on three particularly countries right now, and where I'm working with the ministries of health. So I'm undertaking subnational disease burden estimation in England and in France and in Indonesia. I'm also doing a lot of research on the use of clinical electronic healthcare records that parameterize and are used within our non-fatal models within the GBD, and how the research that I'm undertaking is understanding how to use these better and how to improve those estimates. If the question is more general about research projects within the GBD, this is an enormous question. As I said, there's kind of over nearly 500 people within the study, all doing fantastic amounts of research, and a very big area. And there's like if there's a cause within the GBD, someone's going to be doing research on it, basically.
Um, that is the end of the questions, but we will hang out for a few minutes and give folks additional time if they have questions. Um, please feel free to type them in the chat. Um, otherwise, we just really want to thank everyone for attending. Um, I've posted a link to an evaluation in the chat. And if you have a moment, we'd appreciate you filling it out so we can improve webinars for future learners. So thank you very much for your input. And like we said earlier, the recording will be available on our website, so you can always go back and look at the recording. There is a question coming in. Is the GBD good for students wanting to do a thesis for the GBD for global data or more for country-specific data?
No, I'd say so. You may have detected that I'm originally from the UK based on my accent. And in the UK, I've only been at the Global Burden of Disease Study at IHME for 2 years, so I have less experience there. But in the UK, where I was at University College London, this was something that students did. They used it at a global and a country specific level. So I would say students could take either of those options, but obviously you should talk about the use of the data with your thesis supervisor to really understand that more. But in my experience, I've seen it in both situations, country and global.
Realize. Okay. The link for the survey is now in the chat for everyone. Thanks for raising that. Um, there's a question here, Rob. How does the GBD data get collected from different countries?
Oh wow, that's also a huge question. It is. Oops, excuse me. I didn't mean to do that. Uh, it is very in general. I'll just give a very high level answer because again, we have I think it's literally millions, if not billions, of data points that we collect within the study. But in general, we use health survey data from countries. My team specializes in the use of healthcare records, so inpatient records, pharmacy records, procedure records. We also use cancer registry data. We use surveillance data, so infectious disease surveillance records. That's on the non-fatal side. On the causes of death side, we use vital registration data. We use census data for population uh, size estimates. We use births and fertility data for population records as well. We'll also use police information. We use really it's so extensive and substantial that but those are some of the kind of higher level um, categories. And we generally the way it works is that we have a team that is searching for publicly available versions of those data sets, but also we rely on the huge 17,000 collaborators that we have to provide data to us and identify data to us as well. So it's quite a complex infrastructure and architecture an ecosystem that we have for the collection of data.
Multiple questions of coming in.
Yeah, I saw. Oh, hang on.
Does being affiliated with the IHME provide priority access to the data compared to the public?
um, I mean, I guess as someone working at IHME, I am creating that data, so I guess it's not a priority access, but given that there is a huge amount of checking and vetting of data before it's released. Um, we see that data before it is made public, but we don't get um we do not publish. So for example, the GBD 2023 papers that just came out, we don't publish on those until they come out, and at which point they're made public. Um, there I guess there is a little bit of once the data are finalized, we are able to start using those for publication. So I guess there is a kind of slight priority there, but it's general. It's considered a global public good, and so it's made available for the public as well. I can answer I'm looking at the Q&A, Sean. I can answer the question about models. It's uh there are a range of machine learning hierarchical models within the global burden of disease study. If you wanted to, and again, too many to be able to cover in this session. If you wanted to find out more, um, the best place to look is in the appendices and the publications that were published in GBD, the three main papers that were published for GBD 2023. And you can see those methods and models there. But they really do vary quite substantially depending on the cause, depending on whether we're measuring fatal conditions or non-fatal conditions. And then we have very specific GBD methods. So we use a range of tools. So you'll hear the use of something called DISMOD, which is a compartmental tool for non-fatal disease burden measurement. And then for the fatal side, we're now using a new tool called OneMod. So one model, which is again a complex kind of regression model. But if you want to find out more, do have a dive into the appendices.
Um,
Are the GBD papers publication systematic reviews or no, they're not systematic reviews or meta-analyses. They are we use the data from systematic reviews and meta-analyses, but the the actual modeling approaches that we take vary depending on whether we're looking at deaths or non-fatal causes. So as I mentioned, the non-fatal causes use a compartmental approach generally, using a tool called DISMOD AT. And it's similar to compartmental models that have been more traditionally used for infectious disease modeling. And we use as inputs to those models, the results from systematic reviews and meta-analyses. Um, See many HMS and AIME who research on the GB data and have different teams based on topics of interest. How is this research different? Um, I mean, I don't think there would be any real difference. So if you join as a collaborator, you can interact more with and provide that data. But in general, you will also, if you look in the scientific literature, there are a number of publications by people not affiliated with IHME or HRC who are publishing using GBD data. It is a global public good. It's made available to the global research community for wider use. And in terms of how it's different, I think um, I'm not really sure that yeah, it isn't really that different, apart from the fact that we are the ones creating that data in the first place. And I guess there is like a slight, we would understand how it's generated more, maybe because we spend so much time generating that data. I guess that would probably be the main difference. I think Sean has already answered the question about how do UW students, Sean, do you want to just repeat that, how UW students can get involved?
yeah, the main way we recommend UW students getting involved is through the Department of Health Metric Sciences. The IHME doesn't have a fellowship um, uh, or internships, for example, just due to limited capacity and resources and financing to support those. Students through the Department of Health Metric Sciences sometimes have research assistantships, but those aren't necessarily a guaranteed position, but there are some on staff currently. Um, uh, Sometimes I have seen students who have reached out to faculty independently and asked them to be part of a thesis project or a study. And so that's another way maybe recommend is reaching out to
Mhm.
someone who shares your research interests and connecting to see if there's an opportunity there. Another question, do UW students from other departments be able to get involved with re um typically you can take courses at the department. Any UW student can take courses at the Department of Health Metric Science. I believe there's any research assistantship, uh, those are I've reserved for health metrics department students, I believe.
Yeah, I'm afraid I don't know. I think that other students can do what you're suggesting, Sean, and get in contact with members of faculty as well to see if they have a research project of interest. No, you don't. If you reach out to faculty and they have research projects um of interest, there's no guarantee that, so for example, I have supervised master's theses within HMS. I don't think I have actually supervised anyone yet outside of health metric sciences, but been involved in someone who is a clinical trainee within the School of Medicine that we sit and their thesis dissertation because I agreed to do that as part of their clinical training. So it's not, I don't believe that you have to, but I would encourage you to reach out to your teaching team to find out more about that and to reach out to and take the courses within HMS. We're probably not the best two people to answer these questions. There is a dedicated team there within IHME for these things.
Yeah, I would just recommend reaching out to the Department of Health Metric Sciences. Um, the the academic programs and staff can help guide you in the direction you're looking to go in. Well, thank you everyone for attending. If there aren't any further questions, we'll close the session. We really appreciate everyone joining today. We have a great rest of your day, and um, yeah, thank you very much.
Thanks a lot.
Thanks, everyone.